All right. Good morning, good afternoon, good evening, wherever you're joining us from. We have a great international audience here. We appreciate everyone coming on to this event. And this particular event is going to be a little different than the others. This is the star of this event is the audience. We want to bring in everyone's voice about what they think the right answers are. Before we get started, I just want to actually tell everyone that it is absolutely incredible to me that David Powell and Casey Calkins thought about putting on a virtual event months ago. They had incredible foresight before anyone else did, and it's really paid off. So congratulations to them and an incredible team of Jay, Steve, Ted, Hannah, and Alicia. So we're going to get going with this event, and this one's going to be interactive this way. Here's how we're going to do it. Mac is going to present the cases just like you're used to. Instead of a whole series of cases that last several hours, we're just going to do one tonight, and then we'll do several more over the next several weeks. This particular case is on necrotizing enterocolitis, as you know. And for today, we're going to ask the audience to participate this way. Okay. Text your answers, text your thoughts, text your comments, text why you think we're crazy and why you hate us, and then answer the polls, and I will be the voice of the audience. We also have invited a few panelists to give some talk as well. We have Dr. Gail Besner, Dr. Tom Jaksic, and Dr. Marty Blakely, who are going to give some comments along with the audience. Now, maybe in the future, we're going to bring the audience in by camera as well, but not tonight. So, Mac, take it on. Take it over.
Well, thank you, Todd, Global Cast Ponsky, for our effort at virtual case debates. So if I could have the first slide. All right, next. All right, you're consulting for several days now on a 7-day-old former 25-week premature infant with NEC. The overall medical condition is worsening as defined by not massive but moderate increased ventilator and pressor support, a platelet count that drops and you transfuse and it drops again. We have an abdominal x-ray that shows significant pneumatosis intestinalis, but no clear free air. Next. Next. So you're going to recommend A, continued observation and maximized medical therapy, a bedside laparotomy, OR laparotomy, or a bedside Penrose drain placement. So this is the time to vote.
Go ahead and vote. So Mac, just let me summarize here while we bring on our expert panel here. Basically, we have a newborn who's sick, getting sicker, but doesn't have free air and pneumatosis. They do have pneumatosis. So let's bring on our panel.
Gail, if you don't mind, can I ask you to step in and tell me how often do we see this scenario, do you think? And do you have specific clinical criteria that help you make a decision about surgical intervention?
I guess while we're waiting for Gail, we'll get Gail on, but Mac, here's what the audience is saying right now. So we're getting answers guess what? All over the place, just as you would imagine. It's actually completely divided. The most common answer we see is continued observation and maximize medical management. That's the most common. Now it's changing every second here. We got 30, 32, 33%. The next most common are tied pretty much between bedside laparotomy or OR laparotomy. And to be honest with you, it's really a split around the horn of what people think. So let's see if does anyone have any comments. Mary Brandt says a lot of hot knives out there. A lot of the audience really thinks that we should be operating more. Justin Huntington says bedside laparotomy. We have Dr. Navarro says there's no free air. No free air means keep observing. Don't go unless there's free air. I don't know if that's true. Do we really have to always wait for free air? Is that how we decide to go? I don't know if our panelists are on by sound or anything yet, but
well, I would love some comments from the panelists. I'd love some comments from the panelists about indications for surgical intervention without free air. Gail, can you hear me?
Yes, I just became able to hear you. My apologies. I don't know why I couldn't before. Well, I think if there's free air, putting in a drain is certainly something to consider more highly. In the absence of free air, perhaps if you have a patient that you don't think you can get through the operation safely, and you need to stabilize, perhaps, I think I'd be more likely to do it if the patient had free air.
Well, how about in this scenario where we don't have free air? What are the indications for some sort of surgical intervention? Tom, you have a comment?
Yeah, I think a classic indication is continuing decline despite maximal medical management. And one of the principles is to try to relieve intra-abdominal tension, and that could improve both the ventilatory status by decreasing the PIP and also increase urine output.
So there are reasons to operate without free air. You agree, Mark?
I'm going to interrupt before we get to Dr. Blakely. So there's just an incredible amount of comments, and I want to make sure the audience is heard here.
Good.
It sounds like Brad Warner, he's always got his opinion. Brad says, go to the OR, stop messing around. Brad, he said Bard Parker deficiency, I think is his point. Don't let the skin stand between you and the diagnosis. People say remove the bowel and that'll make the baby better. Some people say that, wait, I don't see portal venous air. I'm not going. I just see pneumatosis. Some people say the baby's getting sicker. It doesn't matter about free air. You don't need portal venous air. The baby's getting sicker. We need to go. Casey Calkins says it's the red belly. That's the kicker for him. So, Marty, what do you say about all that?
Yeah, so I think definitely many babies will have disastrous intra-abdominal findings that don't have free air. So I think we definitely know that. I totally agree with Dr. Jaksic that, don't wait on free air. And this baby in particular just has a hugely distended abdomen, shiny, you can see it from across the room. He's clinically deteriorating. So I think definitely this baby needs an operative intervention. And one of the points I would like to make is I think we are to the point now and in the near future where we really need to think about, when you start thinking about surgical intervention, also really do a careful analysis on what you think this baby has, whether it's NEC or isolated perforation. So this kid's got pneumatosis everywhere. So I would, again, favor laparotomy in this baby.
Thank you. So Todd, it seems like from your reading the comments, this is our classic answer, right? We've got 20% saying one, 20% saying another.
Mac, I feel so bad for you. I feel so bad for you because you can't see what your favorite picture is the pie chart that has every single color of the rainbow. That's exactly what you love, and that's exactly what it looks like.
Right.
However, I have a question for those in the chat. Most of you said continue observation. After this discussion, just curious, has anyone changed their mind? I just want to know, because I know surgeons, we never just stick to our guns. We like to change our mind. Is anyone changing their mind after what they've heard? And just incredible amount of comments, and it goes all different directions. So we do not have a conclusion, although I think the talking went more operative. The polling went more non-operative.
All right, let's go to the next slide if we could pull the PowerPoint back up. All right, so in this particular case, you did a laparotomy and you find necrotic but not perforated bowel 8 centimeters from the ligament of Treitz all the way to the sigmoid colon. So you've got 8 centimeters of clearly viable proximal small bowel. Your plan is to close maybe just the skin and come back for a second look, place a silo, so maybe you can stare at the bowel some more, close and recommend comfort care with only 8 centimeters of small bowel, resect the necrotic bowel, or come up with some other plan.
All right, so we got a lot of sick bowel, no perforation. Well, I am very curious what the audience is going to do. As you can imagine, the chart's going crazy. Let's bring it to our faculty while we wait for the poll results.
Tom, can you kick this one off for us?
Sure. I think the two principles are first, to preserve as much bowel as you can for this child. particularly small bowel, and the other is to relieve intra-abdominal pressure and try to improve the physiology of the baby.
So abdominal compartment syndrome in the neonate's a real thing.
It is, in the sense that you'll see very high ventilatory pressures that you can address, and also anuria, which you can address.
Okay, Todd,
Well,
comments?
let's see. Now we got Mary Brandt saying this is an ethical question, and Dave Magnuson saying, yeah, we need a moral compass now more than we need a good surgical plan. So this is a tough problem. Brad Warner says resect the obvious necrotic and second look if there's a question. Depends how sick the baby is. Ken Azaro says depends how sick. If the kid's dying, take necrotic bowel out. If not, second look. Clip and drop from Dr. Varela. We have, let's see, the poll's changing all over the place. Let's see, let me read the poll. The most common is it's changing every second. Close and second look laparotomy is the most common, but a close second is resect necrotic bowel. I do have a question. There's a tiny sliver of purple that says something else. Please, for you, write in your chat the word something else and what something else is. I'm curious what the other something else is. And some say second look in a 12-year-old 24-hour. So we have answers all over the place.
Gail or Marty, anything to add to Tom's comments?
I just worry a little bit about close and second look laparotomy, because part of the benefit that you might have given to the baby by doing a laparotomy is to relieve any abdominal compartment syndrome. So I don't think that it's a bad idea to consider just putting on a silo. You can then observe the bowel. You don't have to worry about intra-abdominal pressure, and you can do your second look laparotomy. So close just worries me a little. I suppose you could just close the skin, but still that can, really create a lot of pressure as well.
Thank you, Marty.
Yeah, so I would go along with what Dr. Warner said. I think if it's clearly necrotic, I would want to intervene and get rid of that just as a source for ongoing insult to this baby. I also totally agree with Mary. Before doing that, I would probably, run out and talk to the family, let them know what we found. Having done that many times, and I'm sure a lot of people on the call have done that as well. The family, hearing any glimmer of hope, will want you to do every single thing possible. But I favor resecting just that huge source of, necrosis that's going to make this kid just sicker and sicker.
Hey, Tom, can a baby do okay with 8 centimeters of small bowel long term?
They can certainly live. They can be put on cyclopien, and some will actually wean from parenteral nutrition. Necrotizing enterocolitis babies, centimeter per centimeter with small bowel, have the very best prognosis. So the answer is yes. About 40% of them will get significant neurologic damage by 18 to 24 months.
Thanks. Todd, other
Mac, I have to admit something. Usually I can keep up with the chat. I would say literally with this last question, we have over 100 comments. As you can imagine, no one's agreeing. But I think Grant Geisler said something interesting. Talk to the family beforehand so you have an idea. Some people said there's just no chance of baby's going to live with this. Second look, silo, every answer is up there. The least common answer, how about that, is close and recommend comfort care. And to the audience, do me a favor. Because so many comments, if I missed your point and it's important to make, keep copy and pasting it over and over again so I see it, put it in bold letters, and I'll read it out. But there's a lot of comments all over the place.
That's great. Let's go back to the slides again, and we'll move forward a little. All right, the same patient we just presented, but this is what you find on abdominal film. Next. Now that you have free air, you now recommend bedside laparotomy, OR laparotomy, Penrose drain placement, or something else?
So Matt, can I clarify this question? So is this the same baby before going back to the beginning? We never took the baby to the OR. This is the same baby, but different scenario.
Right, same baby, but on that X-ray that we showed before with diffuse
No free air. Now there is
we have free air. That's right.
Okay. So bad neck baby, free air. What do you do? Bedside laparotomy, OR laparotomy, Penrose drain, or something else?
Hey, Marty, could you start us with this one?
Hold on, Marty. Before you answer, Marty, I have a quiz for you. Okay, we're going to play a game because you can't see the polls, right?
Right.
Okay, so Marty, here's your quiz. What do you think is almost 50% of the answers?
I would say drain would be. I would say drain or lap would be close to 50-50 if you combine your two lap options.
So I didn't want to sway you, but yes, almost 50% of the people are saying drain. Go ahead, Marty. What are your thoughts?
So Marty, my question for you would be, how do you decide which to do?
So again, I think it's a bit of a moving target for me. We've had multiple, a couple of large trials that have looked at this. The Larry Moss's trial and then the Piero UK trial. Those trials did not try to distinguish NEC and IP babies. But there's other centers that have done that over time. So Emory and TCH have nice publications that are in the literature where they have tried to operate based on what they think the baby has preoperatively. So with NEC, they do laparotomy, and with IP, they do drainage, and they have good results with the IP group in doing drainage. So I have moved that way. We've just finished this large NEC trial called the Nec Trial. I just submitted that primary paper for review this past weekend. And I can't really say what it showed, but my thinking over time has been it's changed where I really believe what you think the baby has preoperatively is very important and probably should direct your decision making. And that's my opinion based on data. And I think if you've got NEC like this baby, then laparotomy is going to be the better treatment.
Hey, Gail, can we tell if it's isolated ileoperf versus perforated necrotizing enterocolitis on the front end?
So this is a really, really important question. If the abdominal films show pneumatosis, especially in this patient, obviously the previous x-rays showed diffuse pneumatosis, then you know this is necrotizing enterocolitis and not intestinal perforation. But certainly we all know that you can have necrotizing enterocolitis and not see pneumatosis on x-rays. So I personally think that unless you see pneumatosis, I think it's very challenging, even for people that have done this for many, many years, to always be able to accurately differentiate between the two entities preoperatively. In this particular case, though, we know it's necrotizing enterocolitis. It appears to be quite extensive. And so I personally would worry about just putting in a drain, because you're going to be leaving all of this ischemic and necrotic intestine in place. So in this case, I think laparotomy would be preferable.
So quick, Tom, you would do what?
I agree with my colleagues. I think that probably a laparotomy here if you can do it. Now, if you can't do it safely, I think that drainage as a stabilizing measure is very appropriate.
Hey, Marty, when your paper's published, will we know how well surgeons do at predicting isolated ileoperf versus NEC?
You will have some information in that regard. It will not be settled. But I think if I could just debate a little bit on that, it's not all about pneumatosis. I agree with Gail. That's a great discriminator when you have it. We don't always have it. Age of onset is another thing that helps to bucket these babies. The mean age of onset of IP is more like 5 to 7 days. And the mean onset of NEC is more like 21 to 28 days. So that's a pretty good discriminator. And one thing, I'll throw this out for maybe a future debate is I've really gotten in the weeds on the whole IP diagnosis. How that got established. Where we are on just what surgeons think that is. And one of the pushbacks I would have on the accuracy of knowing pre-op versus intra-op correlation, what about intra-op? What if we have some findings intraoperatively and we parade all the people by and say, okay, this kid's got 2 holes, one in the ilium, one in the transverse colon. Somebody would say that's an isolated perf because everything else looks fine. Somebody would say that's neck because it's not. So I think we've got bigger issues than we sort of realize already on the pre-op versus intra-op correlation. And whenever it doesn't correlate, we say, oh yeah, well, we can't tell before, you must be using some weird characteristics. But I think there's probably a lot of variability intra-op on what we're calling things. So I think there's a lot to learn on IP.
Very good. Todd, comments and questions from the audience?
Red Warner wants to know what time of day it is.
It's always midnight.
Questions about, what the size of the baby. There's literally been 100 comments on this. So everything that's been mentioned, every solution you could possibly imagine has been addressed.
How about the poll, Todd, in terms of?
The poll on my end is, there we go. So it's still about the same 44% Penrose drain, 26% bedside laparotomy, 28% OR laparotomy.
Sort of half and half. Yeah. Okay, great. Let's move on to the next question that I think will generate some discussion. All right, you place a drain and 72 hours later, the patient is not improving. So you now hold the course, place another drain, bedside laparotomy or OR laparotomy.
So I have to tell you, Mac, I'm going to bring up our faculty. This is one that I really am curious to hear what the people say about this, because I never know what to do when a drain doesn't. Well, the question is it not working? Or is the kid the same or getting worse? So that's a question here. We're getting. I can tell you right now. Who are you going to go to first?
Marty.
You went to Marty first last time.
I know, but it's on purpose.
Okay, fine. All right. Before we go to Marty, let me ask. Gail. Gail, what do you think the most common answer is?
I hope that the most common answer is to do a laparotomy. I mean, if you put a drain in, what you're looking for is that the patient gets better. Staying the course or getting worse is not what you want to see.
Gail, you're going to be so happy to know that almost everybody said laparotomy. The split is where to do the laparotomy, in the bedside or in the OR. But pretty much there was a few people that said hold the course. So if you're a hold the courser, write why you are a hold the courser, right at the bottom in the text.
And Todd, I intentionally made the question being that they were the same, not clearly getting worse. I intentionally took the middle ground.
Just not getting better. Just not getting better.
Just not getting a lot better after that time.
Okay.
So Marty, what's the role for salvage laparotomy?
Yeah, so I think it's still to be determined. I mean, again, I think if you look at the Larry Moss's study, randomized trial lap versus drain, strongly discouraged subsequent lap after initial drain, didn't totally exclude you being able to do it, but was close to that. They had 55 drain babies and only 5 got subsequent lap. 4 of the 5 lived. In Piero's trial, subsequent lap improved survival over a drain only. So I think I'm encouraged. Actually, I was surprised that most people would pick laparotomy. So I agree with that. I wouldn't have been surprised if there were more just definitive drain. We did it. It's not really working, but that's, we're going to go down with that. So I think that's encouraging to me.
Let me ask.
Tom, can you give your perspective on this, and then we'll open it up to the floor?
I agree. I think as the bottom line, a single surgeon who knows his baby should reassess this patient very carefully. through their course. If they're getting worse, they definitely need a laparotomy. If they're not getting worse, then I think most of us would still do a laparotomy if they were very sick, if you can do it safely.
I think you said something that I want to emphasize, the idea of the surgeon who saw them on the front end being the one who sort of is making this decision daily. It's not just the on-call person. You're making that point, right?
Correct.
Okay.
A couple points, Matt, from the audience here. First of all, Paul Minifee says, if a drain is to work, it works quickly. That's an interesting concept. I'm curious maybe let's do rapid fire comments on that. Just a quick answer. Yes or no. Gail, do you believe that's true? If a drain works, it works quickly.
Depends on what your definition of quickly is, but they might temporarily get better because you're relieving pressure. I wouldn't wait for days. Let's put it that way.
Okay.
I think if they're going to respond to this, it's going to be relatively quick in a day or two.
Another interesting comment is about, it depends on your institution. And I've noticed that depending on where I've operated, this is institutional dependent, how processes work in a hospital. Should it be institutional, Tom, do you think?
Yeah, I really do think so. In terms of bedside laparotomy versus laparotomy in the OR, it really should be institutionally based. There's so many moving parts, and it depends on many, many things. You can do it successfully both ways.
All right, I have a question from Marty from Miguel Gilfond has a question. Okay, and Mac, stop me if I'm like messing up your questions, but he wants to know, what if the drain works? What if the drain works? So now what's your protocol? Baby gets better with a drain. Am I stealing your thunder at all, Mac? Can we do that?
Good,
all right.
Good.
Marty, the drain works. The kid gets better. What do you do?
Well, that's great, right?
Do you do a contrast enema? Do you just feed them? How do you get the drain out? What do you do?
Yeah, so I think just follow them clinically. We tend to back the drain out 10 days or so. And then I don't get a routine contrast enema on every kid. It's a case by case basis. If they're doing well and they're not obstructed, and we might proceed that way.
All right. Brad Warner asks a very interesting question that I've been challenged by the NICU because, Brad, I think I did the wrong thing, as always. I would his point is you shouldn't place a drain if they don't have free air. That it's not going to do anything if they haven't perforated. What are your thoughts on that? Let's say Gail.
In general, I agree with that, although I have seen cases where it has helped. So nothing is 100%, but in general, as I said earlier, I think the patients that are really going to benefit from a drain are the ones who have free air.
Okay. Jack Langer says, if the drain works, don't operate. About a third of babies actually don't ever need an operation. Leave the drain for a week and then slowly remove. So that's his thing.
I guess Jack could tell us the story of the history of the drain from Canada.
Yeah, exactly.
Later
another time. Use abdominal x-ray to guide next steps, some people say. Juan Sola says 10 to 15% of SIPs don't have free air. So that's interesting.
Arguing that a drain might help.
Miguel says the same thing, that free air, it doesn't mean they don't have a perforation. Okay.
Our time is almost up. Dave will be proud that we finished a minute or two early, unless somebody has some burning comment to make at the end here. That'd be great.
So let's do this. I'm going to ask my team to comment to me here. I'm wondering what to do, and either Dave or anyone else. Two choices. Right now, we would usually say to people, so the social lounge is meant to be like the hallway, where you go and talk about things after with the panelists. But to be honest with you, everyone's here right now in this room and the session's over. I would say either stay here and finish your discussion. You can have private chats with people. The video chat may even work, not on everyone's computer. or go to the social lounge and you can network, talk to people, ask questions, people, set up a meeting to go meet somewhere with a private chat. This is how you can meet people if they don't have their contact information. Let me just summarize here, Mac. This was fantastic. I want to thank the faculty for joining this. More importantly, I want to thank the audience who we've had zero attrition. The numbers are still the same. People are engaged. Thank you for Dave Powell, Casey Calkins in taking a chance on something that's really never been done before to this degree, on putting together a true virtual event. This was incredible for me. I learned so much. Thank everyone for coming on. This is not over. This is going to keep going for 10 weeks. And we want to invite all of you back. All this stuff will be available as you come back to the event at any time. Not immediately, but it will be there probably in the day or so, and you'll be able to see all the past content if you missed it. I really want to thank the team, the technology team that has been working day and night to get this done. I can't ask for anything more than what they've done. The Kellen team, this has been spectacular. I'm so excited about this event. Please put comments and questions below, and thank you everyone on camera here. Thanks for joining us. We'll see you Tuesday.